Hello everyone. Today we're going to talk about split cord malformations. Split cord malformations are not very common, but whoever is doing pediatric rotation or have done pediatric rotations, um, they will understand split cord malformation, especially if it's a highly specialized unit. They are important conditions there, and they need to be discussed. I know not many people talk about them or give lectures about them or talk about the surgeries when it comes to split cord malformations. So the importance of discussing or talking about split cord malformations comes from the fact that they are associated with other conditions, other developmental problems. We have to know how to properly investigate them so we don't miss them. We have to highlight the proper timing of surgery, and we have to highlight the important steps during the surgery because they have to be done in a certain way. You cannot just do one step before another one. In general, when it comes to the neural tube defects, we have the open neural tube defects or open spinal dystrophism, which can be a myelomeningocele or myelomeningocele. And you have the closed spinal dystrophism that can be in the form of dermal sinus tracts, lipomyelomeningoceles, split cord malformations, neuroenteric cysts, and thick phylum terminale. All these are under the name neural tube defects or spinal dystrophism. So what's the aim of surgery? Why do we need to operate on these patients? Why don't we leave them alone? First of all, you have to do untethering of the cord. In many of the, especially in the closed ones, many of them are associated with a thickened phylum terminale that's tethering the cord. And as we will see later, a tethered cord is a sensitive cord, and any trauma can result in significant neurological deficit in these cases. We have to preserve the function of the neural tissue, stop it from getting worse as the child grows. The more stretch and the disproportionate growth between the stretched neural tissue will result in more neural damage. We have, in open cases, we have to reconstruct the dural tube, and not only the dural tube, we have to reconstruct and make sure that we do a proper myofascial and skin closure to decrease the incidence of hydrocephalus in some cases, decrease the incidence of infection, CSF leaks that can consequently result in hydrocephalus. Last but not least is minimizing the chances of future retethering of the cord and to try to separate and do an anatomical repair and separate each layer to try to minimize the incidence of readhesions between these layers and the development of retethering of the cord. So timing of surgery is very important in cases of spinal dystrophism in general or neural tube defects. In open cases, you need to do it within 24 hours after birth, or if the child is initially unstable, you delay it until the child is stable, and you can safely delay them for up to 72 hours, because if you delay them more, you will have high incidence of infection, especially if they are leaking, and then you are risking the neural plaque that is viable neural tissue, and that's why we have to preserve it, but that's a different story when we speak about the repair of myelomeningocele. In addition, some epithelialization can happen if you leave it for long. So about our lecture today, what are split cord malformations? So split cord malformations, as we saw in the classification, is they are forms of closed neural tube defects that represent abnormal gastrulation, which is the process during the embryological development. So an MC question can be split cord malformations are open or closed. They are closed and they don't represent an abnormality of neurulation, they represent an abnormality of gastrulation. Previously they were called the diastematomyelia and diplomyelia, but in 1992 Prof. Duckling Pang, for simplification, he classified them into type 1 and type 2 split cord malformations. So the embelliopathy, the problem that happens during the embryological development, is usually like we said, happens during the process of gastrulation, and gastrulation is a period during which it happens during the third week of gestation, and during which there is establishment of the germ layers, so the ectoderm, the mesoderm, and the endoderm. So for the rest of the embryopathy, so it's basically a failure of the notochord to achieve midline integration, and this results in adhesion between the ectoderm and the endoderm with an intervening mesenchyme in between. That results in splitting of the single notochord with a persistent endomesenchymal tract. So each hemineural plate will start neurulating separately because you've done a splitting of the notochord that was supposed to be a single one. The end result is two heminotochords and two hemineural plates, each of which is neurulating separately as we agreed. And they are separated in the midline by a tract containing endoderm, mesenchyme, and ectoderm. So where do these problems or split cord malformation happen? So they basically, in the type 1, which is the one with the bony septum, they happen in lower thoracic and lumbar region, while in type 2, which is the one without the bony septum, in the fibrous bands, it happens in the cervical or upper thoracic region. The reason why is the timing of formation of the endomesenchymal tract. It starts from the rostral part to the caudal part. By the early stages, the mesenchyme is not really forming the dura and the bony septum, but later on it results in formation of this bony septum and the double Turris leaves, in addition to the appearance of the Menick cells, which are responsible for the dural formation and the bone formation. What's the incidence of the split cord malformation? There is no clear known incidence for them. In some literature, it's mentioned to be about 3.8 to 5% of all of the congenital spine anomalies. So 5% of the congenital spine anomalies not in children. In some series, it showed that it's about 0.02%. So 1 in 5,000 of the children is born with that. And it's 3 times more common in females than in males, and they can present from the first week of life up to the 8th decade, depending on the symptoms. So there are a variety of symptoms, and depending on the extent of the condition, they will start presenting. How to diagnose them? How to diagnose a case of split cord malformation? Since we started medical schools, all teaching is you need to do history, clinical examination, and then based on both you will ask for the investigations. So the symptoms, the presenting symptoms, are a bit variable. We will know about these presenting symptoms in the next slide or two, and then you do your clinical examination, and you can find a variety of signs in the form of cutaneous manifestations, orthopedic, neurological, and urological findings. And then you can also find associated other forms of spinal dystrophism, like myelomeningocele or a meningocele. The most common associations with these conditions are low-lying or a tethered cord in about 50% of cases. You can have kyphoscoliosis in about 60% of the cases, syringomyelia secondary to the tethered cord in about 44% of the cases, and spina bifida in about 26% of the cases. We said that we can find lots of signs or manifestations, which can be cutaneous, neurological, urological, and orthopedics. This is a picture of a 4.5 years old child who has significant hypertrichosis in the back. Her mother brought her to our department because she went to lots of doctors, and they said that's abnormal for a child to have this kind of hair distribution on her back. When we scanned her spine, we found split cord type 1. So again, that should draw your attention to some underlying problem. And this is the commonest kind of cutaneous manifestation. You can see this is an intraoperative picture of another child who has, you can see the dotted line is the spine, and you can see she has significant scoliosis. on the right side here, you can see there is a lipoma underneath the skin, and there is a scar of a previous myelomeningocele repair. Other manifestations, we said the hypertrichosis is very common. Capillary hemangiomas, you find a hemangioma on the skin of the back on top of this split cord area, which is the second common. You can find lots of other manifestations: nevus, skin dimples, sinus tracts, lipomas of the under the skin, like you've seen in the last slide. And you can find piny needle cysts and meningoceles. Orthopedic manifestations, they can present with crowding of the ribs secondary to the scoliosis, hemivertebrae, absent spinous process, butterfly vertebrae, wide interpedicular distance. So again, if you scan, if you do an X-ray of somebody's spine, a kid with scoliosis, and you find all these abnormalities, you have to do an MRI, and you have to do a whole spine MRI. Like you see in this one, there is what they call the leg length asymmetry. You can see that the right lower limb or the right leg is longer than the left, and the right foot is bigger than the left foot. And this usually, the bigger, longer one corresponds to the bigger hemichord, and the smaller one corresponds to the smaller hemichord. Other orthopedic manifestations can be elevation of the scapula, scoliosis, kyphoscoliosis, any kind of abnormal curvature of the spine, leg length asymmetry, hip dislocations, foot size asymmetry like we've seen, valgus, varus, and cavus foot deformities, and vertebral body abnormalities or deformities like in the last slide. Neurological manifestation, again, the problem with the neurological manifestations, they are variable and they depend on the age of the patient at the time of presentation. In infants, they usually don't move their legs as much, so there is a decreased spontaneous leg movement. In toddlers, they have decreased spontaneous leg movement and developmental delay. They are not standing at the right time. They're not walking like their other children at the same age are walking. In older children, they present with back pain, complaining always back pain when they play, in addition to the urinary incontinence. And in young adults, they present with back pain. So neurological manifestations are different, but mainly as the child grows, they start to be in the form of the back pain if they didn't have any developmental delay when they were growing up. And this is a table of the neurological deficits at different ages. You can see it's the difference in infants, toddlers, older children, and young adults. And with the young adults, this goes up to the elderly. So any adult with back pain, leg cramping, sometimes they start developing these problems. And they can be diagnosed incidentally. Just because we're investigating the back pain, they can be diagnosed with a split cord malformation, and they're surprised that this is congenital, but this is one of the congenital conditions that can persist and diagnosed late in life. Urological manifestations in children, they will have toilet training delay. It's difficult for the parents to train them to for toilet. Primary enuresis or secondary enuresis, they were controlling themselves and then they lost this control. Recurrent urinary tract infections, because we've said again, one of the other factors is that it's more common in females than in males. So with this enuresis, precipitancy, incontinence, that can result in urinary tract infections, recurrent ones, and the new onset of the incontinence or retention. How do we diagnose them radiologically? You've listened to the history from the parents, or if he's a child who can communicate well, or a young adult, and they told you about their symptoms, you're suspecting it. So how do you diagnose it radiologically? If you do a plain radiograph, you will see all kinds of the orthopedic manifestations we've talked about: hemivertebrae, split spinous process, absent spinous process, thickened lamina, butterfly vertebrae, wide intervertebral distance. You name it, you'll find any of these problems. The MRI, again, one of our gold standards to use in diagnosing many of our neurosurgical problems, and you will find the two hemichords, and you can find any other associated lesions like lipoma, the cords, myelomeningocele, all the fibrous bands, you can sometimes see them. CT scan, if you want to highlight the bony problems, the bony anomalies, you can see the bony septum properly. You can see the extent of the bony septum. So when you're planning your surgery, you have a better plan. You know where you're going to expose the spine from. You have to plan your skin incision. And then the most sensitive is the CT myelogram. And we will later we will see why the CT myelogram is important. This is a plain radiograph or X-ray of the vertebral anomalies, and you can see the wide interpedicular distance. You can see absent spinous process and a hemivertebral lower down. This is an MRI that shows the double Dura sleeves, and it also shows the two hemichords sitting there in the Dural sleeves. So how do we manage these cases? What should you do for these cases? Should you watch, wait and watch? Conservative management, is it surgical, is it medical? We agree that there is nothing medical that you can do for these patients unless you're treating symptoms only, which you shouldn't be your aim when you're doing medicine in general, except in certain cases. There is always an exception, but this is not the rule. You can use medical treatment to treat symptoms if you cannot treat the primary disease, which is the least that you can do. But for these cases, all cases require surgical intervention. And why do we say that all cases require surgical intervention? That's because from our literature and the studies and the centers that have seen all these patients, they found that 85% will deteriorate versus only 4.5% will deteriorate from surgery, neurologically. Because all the stretched sensitive cord as the child grows or the young adult grows, or even the adult with this problem, if they have a trauma to this stretched cord, they will end up with a neurological deficit, and oftentimes it is not reversible, versus only 4.5% deterioration from the operation. The cases that can be left without an operation are patients who are elderly and they are not leading a very active life. They are not going out and playing and jumping around, so their instance of having a trauma that can cause a significant neurological deficit is not as high as somebody who's leading an active life. You do operate even in asymptomatic patients. Asymptomatic if you find it incidentally in somebody who's really active, an athlete who's having some back pain, because their instance of having a trauma is higher than anyone, or even if it's a minor trauma that wouldn't do anything for somebody who's normal, that can cause them to develop a neurological deficit. So that's why you need to operate on them even if they are not significantly symptomatic. For the surgical management, is it different between type 1 and type 2? And is it the same aim for both of them? The answer is no, because in type 1, there is a bony septum that you have to remove, and there are double dural sleeves that started as a single dural sleeve, doubled, and then reunited again lower down. And usually the split is about 1 to 3 vertebral segments. So your aim is to remove this bony septum, it's tethering the cord, remove this dural sleeve that is tethering the cord, and then convert it into a single dural tube. In type 2, you don't have a double dural tubes, you have two cords sitting in a single dural tube. So what's the problem? The problem is there are lots of fibrous bands, especially anteriorly, that are tethering the cord to the anterior dura, and these are the adhesions that you need to cut, or the fibrous bands that you need to cut. So you do that for type 1 or type 2. Is it all? The answer is no, as we agreed that you need to look for other surgical targets that you need to remove, lipomas, any myelomeningocele that you need to repair at the same time, and untether the cord. Oftentimes you need to untether the cord. You're there, it's the same operation, and you have neurophysiological monitoring. There are ways clinically to identify it, so you need to untether the file. So that's very important. The timing is very important as well, and it's crucial. For the surgical planning, and this is one of the most important things, you have to preoperatively prepare your patient. Neurophysiological monitoring is important in these cases. You have to plan your skin incision. You have to expose from normal to abnormal. You cannot go into an abnormal area where there is a split of the spinous process, when there is a thickened lamina. You don't know your anatomy, it's dangerous. You have to be very careful if you're using your diathermy or bovine, because you can go into the dura, and a burned cut edge of the dura is not something that's going to heal, which is bad, and you can injure the neural tissue underneath. So you have to be very careful when you're using it. So don't do a small incision trying to be minimal. These cases are not the typical cases for minimal approaches. In addition, you don't want to be minimal to the skin and then be maximally damaging the neural tissue. So you have to properly plan your skin incision. You have to plan your exposure. Expose your fascia, because you will need it to properly repair. Sometimes you can use parts of the lateral lumbosacral fascia to repair the dura if there is any defect in other conditions. You have to be careful when you're doing your laminectomy. Like we said, you have two dural tubes and you have to do the laminectomy, remove all the bone until you leave the island of bone sitting between the dural sleeves alone, and then you can remove it. Dural opening differs between type 1 and type 2. We will see that. And then the closure, which is very important and crucial, and how to properly close in order to decrease the incidence of a CSF leak and an infection. And of course, the retethering of the cord, that should always be in your mind when you're doing these operations. The anterior dural defect that is present in some cases, it's not usually a big problem. The dura is adherent to the posterior longitudinal ligament, and usually there is no significant CSF leak or a pseudomeningocele formation from an anterior dural defect after you remove the dural sleeve. So usually don't worry too much about them. If you cannot repair it, don't worry too much, because otherwise you'll end up with multiple holes in the dura that is causing more problem than what you've started with. We said that there are difference between type 1 and type 2 in terms of the bony exposure. You don't have to do significant bony exposure in type 2, and the dural opening again is different, because you do a linear incision in the dura in type 2 because it's a single dural tube, while in type 1 there are multiple dural type 1, there are two dural sleeves that you need to do an elliptical incision to excise this dural sleeve. Dissection is very important. You do a bit more dissection in type 2 because there are lots of fibrous bands, in addition to the medial roots in type 1 that end up into the dural sleeve. You don't worry too much about them and you can excise them. This is the picture, and the operative pictures are from Wilkins Operative Atlas, and you can see here in the first one he's removing the bone and doing a laminectomy, and then in the second picture they are dissecting around the bony septum, and as you can see in the third picture, the bony septum is being removed. When you remove the bony septum, sometimes you find brisk bleeding coming from the bone. You can wax it and you can wait a bit before you open the dura in order to stop any blood from trickling into the subarachnoid space. This is how you open the dura: linear, and an elliptical in between around the dura sleeve, and then you dissect the median nerve roots away from it. You can cut them, they are not a big issue, and then you need to remove the dural sleeve in the first picture, and you can see they are untethering the cord close to the coraequinal nerve roots. This is, again, as we said, it's important, and you have to try to do it whenever you can. Next step is going to be a linear closure of the dura, forming a single dural tube. So if you cannot see this fibrous septum properly, what would you do? What would you do then is that you need to do a CT myelogram, which, as we agreed before, is the most sensitive in picking up all these fibrous bands and fibrous adhesions, and that can help you identify some of them that you would have missed without a CT myelogram. This is one of our cases, long time ago, 11-year-old boy who presented with low back pain and urinary precipitancy. His neurological examination was more or less free, and his MRI showed a splitting of the cord between L1 to L3 with the presence of a bony septum. In addition, he had a low-lying cord that was almost at the level of the L5S1. These are the images of the patient. You can see from the x-ray the abnormality of the vertebra, absent spinous process, and absent part of the lamina. In the MRI, you can see the two hemichords with the left side being a bit bigger than the right side, but you can see the two hemichords each sitting in its dural tube. Intraoperative picture after we've done the laminectomy, you can see the island of bone sitting there between the dural sleeves. This is after we have removed the bony septum. And this is a post-operative MRI scan, sagittal view, showing the gap that you can see between the two cut edges of the filum terminal, the thickened. You can see how thick the filum terminal was. The take-home message, there are lots of important things that you should be aware of. The clinical picture is very important. If you see a child, young adult, with one of the cutaneous manifestations, that should draw your attention to a possibility of an underlying splitting of the cord or an underlying spinal abnormality that needs to be properly investigated by an MRI scan or CT myelogram. The second one is that a whole spine MRI is mandatory in all cases. Don't count that you have done a lumbar MRI, you've seen your split. You need to scan the rest of the neuraxis. In certain cases of tumors, in all cases of the congenital anomalies, you have to scan the whole neuraxis in order to be able to pick up any other anomalies along the CNS that might be causing a problem or might be causing a secondary problem to what you've seen. So always scan the whole neuraxis, especially the rest of the spine in split cord malformation cases. You can see type 1 lower down, and then you scan the rest of the cord and you will be surprised to see a type 2 higher up in the cervical or lower thoracic or upper thoracic region, or you can see serings that you need to follow up in the future to see if it's improving or not. We need to operate even if it's prophylactic, and we've said why. Stretched cord is a sensitive cord, and they can develop significant problems from the minor trauma that wouldn't hurt anybody else. Untether the cord if tested, and usually that's required in all the cases. And the timing of untethering is very important during the surgery. You have to untether the cord after you have removed the proximal tethering element, which are the fibrous bands in type 2 or the bony septum and the dural sleeve in type 1. If you untether the cord first, you're asking for a recoil of the cord against this bony septum and a dural sleeve, and that can cause significant irreversible neural damage. So in order to minimize that, leave the cord stretched for you, do the proximal untethering first, and then you can do your distal untethering after that. These are the main things. Please, if you have any questions, don't hesitate. Write it down in the comments. All the best for everyone.